This is the common word we see in the era of Zoom, I think. Again, thank you very much for inviting me to speak with you regarding hepatitis B in African community. And Catherine asked me to talk about, I think it was emphasis, what are special things, considerations in this high risk African community. That's what I'm gonna try to do, but it won't be. The discussion won't be complete unless I review some background information. So what I'm going to do is I'm going to talk about some epidemiologists. I'm sure we talked about epidemiologists in the past, but I'm going to mention some unique issues in African population. Again, I'm going to talk about treatment, maybe quickly pass through that, just to give us an idea about what treatments are available, what the guidelines are saying in regard to treating hepatitis B. And finally, I'm going to talk about some cultural competencies coined around, the African community. Of course, you know that hepatitis B is a DNA virus, and that's actually the main reason why we struggle, because it's a long-term, infection. Once an individual is exposed, they tend to leave its footprint in DNA. It's very difficult to eradicate. That's why in chronic hepatitis B, treatment tend to be long-term, and in fact, lifelong. Bloodborne transmission is a way how hepatitis B is transmitted. Vertical perinatal transmission, particularly in these high endemic areas. As you know that up to 90% of infants born to hepatitis B infected mothers could develop hepatitis B infection. To be honest with you, and in my opinion, actually one of the most successful public health intervention in US is in the late 80s, where we start to screen all pregnant women for hepatitis B, and later on coupled with introduction of vaccine to infants led to a rapid decline of incidence of hepatitis B. So that's worth noting here. Other ways of transmission: injection drug use, sexual contact, and of course percutaneous and mucosal exposures. Hepatitis B is the most common viral hepatitis worldwide. In fact, the estimate is about 257 million people worldwide affected by this viral infection. In US, well, the estimate is about 2 million Americans are affected with hepatitis B. In African communities, about 75 million people with hepatitis B is estimated to live in Africa. Now, I confess that there is limitation in this data, right? We don't have adequate data. Even those data we have is limited to metropolitan areas and some high-risk groups within the African community. But I can tell you that based on the available information, if you take South Sudan, Liberia, Guinea, very high risk in the estimate of greater than 50%, 15% of population have hepatitis B infection. The estimate in Nigeria, Senegal, and data from Somalia and Zimbabwe confirm a prevalence between 9.8% to 14%. I was born and raised in Ethiopia, and the data we have is between 2.5 and 6% of population affected by this. Again, I say that this is generated based on the available data. It may not represent the actual national or regional data. Well, the other concerning this, in addition to the high prevalence of hepatitis B in African communities, hepatitis B tend to be more severe in African communities. Liver cancer is the third most common cancer in Africa. In fact, hepatitis B is a leading risk factor for liver cancer in that continent. Up to 65% of liver cancer could be attributed to hepatitis B infection. Of Of course, you can talk about other factors that can lead to liver cancer. But again, I would like to underline hepatitis B remain to be the reason for hepatitis B in more than 50% of cases. Now, even if you look at immigrant population data from US, we know that HCC is diagnosed, liver cancer is diagnosed at a younger age and tend to be actually a late stage diagnosis. Usually individuals present to healthcare with symptoms, and on imaging study, we identify these large multiple lesions and perhaps with metastasis and a high alpha fetoprotein, which will put them outside the resection criteria, or curative treatment criteria. Hence, in fact, data from New York have shown that HCC-related mortality is much, much higher in African immigrant community. Again, as I mentioned, the consensus in US is that more than about 2 million people are affected by hepatitis B. Now, again, the majority of these individuals are actually immigrant patients, people who come from these high, moderate to high endemic areas. The estimate here in US, based on, again, some metropolitan areas, is about 10% of this immigrant community have a hepatitis B history or exposure or infection in the past. The unfortunate fact is that the majority of patients, actually individuals, are actually unaware of their hepatitis B infection. Even in those who are diagnosed with hepatitis B, very, very small amounts are, or a proportion of individuals or patients are linked to care and receiving therapy. And this is true actually not only for African communities, but also the other immigrant communities as well. Now, it's very important. One of the reasons why hepatitis B underdiagnosed and undertreated is the nature of the progression of liver disease itself. Of course, I'm going to talk about other barriers to care, in particularly in hepatitis B African patients communities. But I just want to mention that, once an individual is exposed to hepatitis B, of course they can develop an acute infection and acute hepatitis. But the majority of patients actually have some subclinical hepatitis. They may not seek a care for the infection. In most cases, they may not be aware of it. In addition, as we mentioned, most of the immigrant community probably have already been exposed before migrating to US. It's worth noting that once hepatitis B infection, chronic hepatitis B infection is established, there is a very good chance, about 40% of patients will progress to advanced liver disease and cirrhosis. Again, it's not infrequent that I get questions with why some patients develop advanced liver disease and why some patients have a milder disease from hepatitis. That's a tricky question to answer, but I just want to make sure that you understand there are several factors which determine the progression of hepatitis B to advanced liver disease or related complications. Of course, the viral variables, for example, the presence of co-infection with hepatitis C. You have discussed this in the past, co-infection, superinfection with hepatitis D. The viral count, viral genotype, all play a role in the risk of progression of liver disease. And that's the reason, actually, these variables also a reason in determining whether to initiate therapy or not. Host factors are still there. The individual's immune status, immune suppressed individuals have a high risk of progression of liver disease. The presence of other environmental factors, including the presence of NASH, presence of the consumption, alcohol-related injury, and other factors can precipitate or rapid progression of liver disease in hepatitis B infected individuals. Now, we know that the strong predictor for liver cancer in hepatitis B patients is the presence of cirrhosis. but it's very important to understand that hepatitis B by itself is oncogenic virus. That means that it can cause, or it's a risk factor for liver cancer, even in the absence of advanced fibrosis or cirrhosis. And that's the case in 30 or 50% of cases. And that is the reason also that the guidelines, even if in my opinion, are really conservative in initiating, when to initiate hepatoma screening in hepatitis B infected patients, but also guidelines actually recommend that in individuals based on their age, the family history of liver cancer, even in the absence of hepatitis cirrhosis, we have to initiate hepatoma screening and continue with adequate effective surveillance to pick HCC at the early age, so we can offer therapy. Now, quickly, okay, how do we diagnose hepatitis B? Of course, the most commonly tested serologic markers include, surface antigen. As you know, it's a marker of presence of infection. And on the other hand, the presence of antibody against this hepatitis B surface antigen indicates that the presence developed immunity, either from recovery or vaccination. Well, to understand if somebody has exposed to hepatitis B or has infection, hepatitis B core antibody has a role. That tells you it's a prior exposure. In fact, we use it, as you know, in the presence of core antibody IgM. You can tell that this is a recent infection or acute infection. Well, hepatitis B antigen is usually associated with active replication. And in fact, with active replication, these patients or individuals tend to have a high HBV DNA viral load, and that means the infectivity, risk of infectivity, or the chance of infectivity is high in these individuals. In fact, high hepatitis B DNA is also linked with the risk of development of hepatocellular carcinoma, as well as the risk of progression of liver disease. And that's the reason, actually, of all the variables to initiate therapy, the presence or absence of E antigen status and the viral load cutoff points are usually used by several guidelines to recommend whether to initiate antiviral therapy or not. And again, if a person have a hepatitis B surface antigen, that indicates the presence of hepatitis B. To identify if it is a chronic infection or an acute infection, again, the presence of hepatitis B core IgM will be tremendous help. Remember, in actual acute hepatitis B infection, in most cases, these patients are sicker patients. These are a typical jaundiced and patients with significantly elevated liver chemistries indicating active and acute liver inflammation. So how do we manage hepatitis B in general, and of course in African patients? It starts with, these are at-risk populations, so we have to start with offering screening tests. And the advantage of screening is if somebody is, hepatitis B surface antigen, of course, we put them through the track of further evaluation and identifying, a degree of liver disease. We have to evaluate whether they require therapy. We have to initiate screening and surveillance of screening and continuous surveillance of liver cancer. And then these patients also will regular follow-up. The other advantage of screening is, mind you, in these high-risk patients with potentially high chance of having household contact and identifying the absence of surface antigen. Identifying an individual who is susceptible for hepatitis B infection should prompt you to offer them vaccination so that they can have long-term protection for hepatitis B infection. This is one of my selling points when I participate in community talks or community screening program to encourage individuals to get tested, not only to identify hepatitis B infection, but also if they don't have the infection, this is the time to consider appropriate protective measures, including appropriate vaccination and long-term protection. You all know that the CDC recommendation of screening high-risk individuals. I'm not going to go through that, but I just want to underline and bring back to your attention again those individuals who migrated from these high prevalence areas should be offered screening tests. Again, even in US-born people who are not vaccinated and as an infant, but more born from those individuals from hyper-endemic areas should be offered a screening. It's not frequent, again, that as a provider we miss that we care for hepatitis B patients, but we miss counseling or offering household contacts and sexual contacts to get a appropriate screening test and get vaccination if they're not infected. So that's something I will come back later on. How do we evaluate? This is my approach. Again, there is a consensus in this regard. Once you have a patient with hepatitis B, again, surface antigen, the next step will be evaluate the hepatitis B activity and the degree of liver damage. For me, ALT is a very good marker for a degree of liver inflammation. Hepatitis B DNA viral load will tell you the activity. E antigen, again, infectivity and also replication status can be identified. That also help you in identifying or decision making in regard to therapy. It is very rare these days we do a liver biopsy to evaluate degree of fibrosis in hepatitis B patients. There are several non-invasive markers which are validated that you can use, be it imaging study, measuring stiffness, or based on, for example, APRI score. You should feel comfortable using these non-invasive markers in assessing degree of fibrosis, stage of fibrosis in your patients. Regarding screening hepatitis HCC in hepatitis B patients, ultrasound with or without alpha-fetoprotein is a good screening test. For me, I continue to use alpha-fetoprotein coupled with ultrasound every 6 months in these individuals. Assessing comorbid situation is very important because that in a patient who have co-infection, you need to be aggressive in treating them. Make sure you screen your patient for hepatitis B so we can vaccinate them. This patient need to be counseled with alcoholic liver disease because the presence of alcoholic liver disease, and there is a mounting data suggesting the presence of non-alcoholic steatohepatitis along with hepatitis B. And these patients tend to do poorly with rapid progression of liver disease, development of HCC. In fact, the tricky part in these patients with NASH is that this is a patient where you put aggressive therapy for or initiate them with antiviral therapy. They tend to have persistently elevated liver enzymes. That is the area where you might need a biopsy and implement some metabolic interventions to address their fatty liver disease. The other important comorbidity in patients, particularly those you initiate therapy, but you have viral suppression. You continue to see persistently elevated liver enzymes. Look for hepatitis D superinfection. In fact, we recommended to screen hepatitis B patients at the beginning for D infection, but D infection is serious. Superinfection is serious as the patient can have a high risk for progression of cirrhosis and decomposition, of course, liver cancer. I check for bone health, renal function, because once you embark in therapy, that these patients will need long-term therapy, and then renal health and bone health will be very very important. Again, please, while caring for hepatitis B infected individuals, you have to counsel them and offer them, encourage them to get screen their household contacts and sexual contacts. I brought these phases of hepatitis B infection so that we can have kind of a consensus why the guidelines suggest, what they suggest or recommend who should be treated. In immune tolerant phase, even if their individuals have high viral load, the degree of inflammation is very low. In fact, these patients will have perfectly normal liver enzymes despite having millions counts of hepatitis B viral DNA. And these patients tend to do, if you have assessment of their fibrosis or inflammation, they tend to have really common and mild liver disease on a biopsy. Similar in immune control or inactive, what we call inactive carriers. Again, the viral load will be non-detectable and liver enzymes are normal. Now, the guidelines suggest to monitor these patients. Of course, look for other factors, presence of fibrosis, a history of HCC, or comorbidities, things like that, to guide you whether in an individual basis to initiate therapy or not. But most importantly, in those immune reactive patients where you will see fluctuating high viral load along with elevated liver enzymes, these patients tend to have active disease, should be treated. Immune escape, again, E antigen negative hepatitis. Similarly, the viral load inflammation numbers are high. The viral load may not be as high as those individuals who E antigen positive, but these patients are also at risk of progression of liver disease. We have several medications approved and over the years, from interferon, lamivudine, adefovir, and entecavir, interferon pegylated form, talbuvidine, tenofovir, now with tenofovir alfenamide, which is a prodrug, are all available. I highlighted entecavir, tenofovir, alfenamide, because those are the most commonly used antiviral agents currently here in US. Again, you did have, I think Dr. Gish gave a talk about treatment of hepatitis B, so I'm not going to go in detail with this. But what I would like to talk about is what are the current recommendations? Who should be treated? This is a summary where when you select therapy, these are the patients you should select for treatment. In patients who have active hepatitis B, defined by high viral load, as I mentioned earlier, and or inflammatory activity, which is ALT in this case, is a very good marker. The presence of cirrhosis is no question. Family history of HCC, you should be more aggressive initiating therapy in this group of individuals than somebody who have no family history of liver disease. Transplant patients, patients who are immunosuppressed, patients who are undergoing chemotherapy should be screened and treated accordingly. Co-infections are also at risk of progression of liver disease. So you should consider or have a low threshold to initiate therapy in these patients. What's your goal of therapy? Well, the primary goal is, of course, to suppress the viral. This is a long-term, this is a antiviral suppressive therapy. Your first goal should be achieving suppression of the viral load in these patients. Of course, in the long term, and data have proven that in these patients, after suppression of viral load, normalization of liver enzymes will come in some patients, regression of fibrosis. The risk of, there is ample data showing that the risk of HCC is much lower in treated individuals compared to patients with active disease. No matter what agent you use, the presence, suppression of virus leads to reduction of HCC risk, and these patients will have improved survival. These are the goals. The guidelines are a little bit complex, to be honest with you, but this is, I took this a couple of slides from Professor Ann Locke when she gave a talk to a virtual symposium in 2002 with APSL WGO. From the get-go, there is a consensus that in cirrhotic patients, you should initiate therapy. ASLD, EASL guidelines says go and treat these patients. APASL is just, decompensated liver disease, abnormal liver disease, or patients should be initiate treatment, maybe in compensated liver disease, high viral load HBV DNA cutoff greater than 2000, you should consider therapy. For me, my recommendation, my practice, what I do is that if I have a patient with cirrhosis, no matter their liver enzymes and hepatitis B DNA level, I will initiate antiviral therapy in these patients. It's a little bit complex or variable recommendation in patients without cirrhosis. EASL perhaps is the most aggressive and straightforward. No matter hepatitis B antigen status, if a patient have viral load greater than 2000 IU per ml and elevated ALT upper limit normal and moderate inflammation or fibrosis, then go ahead and treat these patients. If hepatitis B DNA greater than 20,000 and ALT greater than 2 times upper limit normal, you should offer, this is the recommendation from EASL guidelines saying that you should offer therapy. APASL and ASLD divide the recommendation relative to hepatitis B antigen status. As you know, hepatitis B antigen positive patients using a high viral load cutoff point, 20,000, compared to E antigen negative patients greater than 2,000. I will leave this to you to go over the guidelines when you have a patient, when you consider treatment. I'm not going to go through this at this point for this discussion. But okay, now, it's easy to screen patients, right? And high-risk individuals. And we have kind of stated guidelines to how to manage these patients. So what is our problem in getting patients to care in hepatitis B in high-risk African communities? There are several factors, and in fact, you have to, and maybe several factors at play in each individual. And I stole this diagram and some of the text from publication by Catherine and her colleagues recently based on their qualitative study. And as you can see that, religious values, culture norms, people's perception and knowledge about the disease, access to health care, financial issues, even the knowledge and myth about hepatitis B has a role. I can give you some of the examples. So some of the reasons why patients doesn't get a screen or get care in regard to hepatitis B, they don't know. They don't know. In African communities, they are not aware actually liver disease could be caused by a virus. Mostly they attributed liver disease, in this case jaundice, caused by alcohol rather than other causes. There are cultural beliefs that actually liver disease or liver cancer, particularly liver cancer, is caused by or due to punishment from God. Religious values, lack of trust in modern medicine, it's across the board. And also people prefer alternative care. So these are the things you need to consider in addressing when you design public health intervention or community intervention in a screening and care of these high risk. Fear of stigmatization. I can give you an example. People are ashamed to get tested. Even in East Coast in our area, in Ethiopian community, what we come up with was combine the hepatitis B screening programs with other health care, for example, screening blood tests, diabetes screening, high blood pressure, obesity screening. And in fact, at one point, we brought the fibroscan test to the church so that people can come without feeling, bad about getting the hepatitis B screening along with the other cares. These are the things I think you need to consider in your intervention. Cost of care. This is, a migrant community, poor community. In most cases, they may not have adequate insurance. So that might be a limiting factor in some of these cases. We are also playing a role, as I mentioned earlier. It's not infrequent that we lack to offer. We see them in our practice for other diseases, but we fail to offer them a screening test. As I mentioned, CDC is really clear about these patients from high risk, migrated from these high risk geographic areas. We should offer them a screening test, including their household contacts. Language barrier. Most people, when they come to this country, they feel that they have a health checkup, and they think that they were screened for hepatitis, all problems. So they might tell you that they might tell you they've been screened in the past, but I recommend that you screen them and have the documentation here, because in most cases there is a misunderstanding that hepatitis B may not be part of their health checkup before migrating to this country. Other factors, lack of access to preventive care. I mentioned about insurance, and then lack of social support. Again, most importantly, as stated by Catherine Freelander and her colleagues, there is not only one factor, but there are several factors at play. So it is important to acknowledge these variables and address it in your intervention. With this, and I'm sorry for taking extra time, Catherine, but I just like to conclude with this information. Now, I hope that I gave you that. Yes, the prevalence of hepatitis B worldwide is high, right? But African communities are particularly come from a very high hyperendemic area. In most cases, they are underdiagnosed and they don't know they're infected or not. We have guidelines for screening, and then the recommendation is these individuals should be, we should offer them screening tests. Hepatitis B is preventable. One of the advantages of screening is to identify those individuals who are susceptible so we can vaccinate them appropriately. And these vaccinations are pretty effective. If you identify a patient with hepatitis B and diagnose chronic hepatitis B, then you should evaluate them and evaluate them for therapy. And if you initiate therapy, your goal of therapy is the primary goal of therapy is viral suppression, and you have to educate your patients about this because this is a long-term therapy, and from the get-go you have to let them know probably this is a lifelong care and treatment, so that they will remain compliant with your follow-up. And then again, in my opinion, lack of disease awareness and fear of stigmatization perhaps the major barriers to hepatitis B care in particularly in high-risk African communities. I mean, with these few pointers, take-home messages, I would like to conclude my talk. And again, thank you for inviting me to give this short presentation. Thank you.
Thank you so much. This was really helpful. I know we had a question from Myra in the chat box. Myra, I'd like to invite you to share. I think you had a couple of them, so it probably would be easier if you're able to turn yourself off mute.
Hi, thank you so much. This was a really great presentation. A couple of things that I took note of that I wanted to be clear on. Number one, I asked the question about patients who may present with solely a positive core, which would suggest that they have been exposed to or cleared a Hep B infection. How long will you surveil those patients, and what means would you do? Would you simply get a viral load maybe every 6 months to a year? Should I couple that with an ultrasound? Of course, looking at them in physical exam, if I see something, I may send them for an ultrasound or an AFP. Like, I want to throw everything against the wall, but I'd like to pick your brain on what you think about that. And then my other question was, and perhaps I caught this in passing and didn't get all the details. I want to be accurate. I have quite a few patients that I see in primary care, and they'll have this unusual presentation for an elevated AST and ALT, and I'll do a GGT to make sure that they're not drinking, and of course that's low. And I'm like, what's going on? They'll have this occasional abdominal pain, a transient nausea. I may send them for an ultrasound of the abdomen, but I guess what I'm hearing you say is perhaps I should check them as well for occult or some low-level hepatitis B exposure.
Okay. Thank you very much. Actually, you raise a very two important points, but allow me to answer the second question first. Yes, one of the workup, the evaluation for those patients or individuals with abnormal liver chemistries should be evaluating them for hepatitis B. I think this is not just for high risk group, but as part of anybody who presented with this unexplained elevated liver enzymes. And the chances are actually this might be metabolic issue, fatty liver disease, but yes, you have to, it's as you stated, you have to screen them for viral infection. And I will add in that actually hepatitis C, since it is very common in here in US. Again, so the core antibody, isolated core antibody positive is a tricky question, right? So what are the explanation for an individual who have isolated core antibody? There are 4 explanations. One is, of course, somebody who was previously exposed to hepatitis B and cleared it, resolved infection, which is the most common explanation, right? Don't be surprised that the isolated core antibody to be a false positive result. Individuals with acute infection of any some other source. Remember, the tests are, kind of ELISA tests, right? They will look for possible presence of possible antibody antigen reaction. So there might be cross reactivity with somebody who's acutely infected for other reasons. So that might be a reason for a core antibodies. And if you repeat this, once their infection is resolved, the false positivity will disappear with that. Somebody who have a recent infection, acute infection, and resolving, they can have a core antibody positive state. And in case, you get a IgM test in this individual. So if you repeat this test, 12 weeks, 6 months later, you will see the core antibody changing from IgM to IgG. That will give you a comfort. Now they completely cleared the virus, especially in the absence of hepatitis B surface antigen. Now, one of the challenge is, core antibody can be a marker of chronic infection, where individuals have very low non-detectable surface antigen and non-detectable hepatitis B DNA viral load. It's very uncommon, but it's a possible explanation. But for me, if you give me a patient, if you send me a patient to sort out what is this isolated core antibody, number one, I will check if it is IgM or not. And then obviously I will repeat it at 12 weeks, 6 months, and then I will sign off on that patient. That's what I'm going to do. Thank you.
Thank you very much. I have a list of patients who are core positive, and I've been keeping my eye on them. Thank you.
Yeah.
Great, thank you. And as I'm transitioning, Dr. Faisal, you mentioned screening